To summarize this chapter on coronary artery disease, we're using a segmental approach where we divide the ventricle in a basal, a mid, and a distal segment, and then we subdivide so that we arise with 16 or 17 segments depending on which model we use. The 17th segment would be the supraapical cap. These segments correlate or correspond to perfusion territories of the coronary arteries. We can describe different degrees of wall motion abnormalities ranging from akinesia, where no motion is present, to hyperkinesia, where excessive motion and thickening of the endocardium is present. There are various different conditions of perfusion and necrosis, such as ischemia, scar, hibernation, and stunning. Remember, stunning, hibernation, and ischemia are all associated with normal wall thickness. These various conditions can be present in the same patient, even in the same view. Remodeling is an important concept which is usually caused by large infarcts where we have progressive deterioration of left ventricular function, which also affects segments which are not infarcted. The assessment of regional wall motion abnormalities is probably one of the most difficult tasks in echocardiography, so you need a lot of practice and you have to optimize your views. There are various patterns of myocardial infarction depending on which vessel was occluded and how long the vessel had been occluded. How can you remember the different complications of myocardial infarction? Remember the word armpit, A for aneurysm, R for rupture and pseudoaneurysm, which is a form of rupture, M for mitral regurgitation, P for papillary muscle rupture, I for ischemic VSD, T for thrombus, S for shock. The only thing that is not included is RV infarct. Some specific features and findings of the complications: rupture has a high mortality, is associated with pericardial effusion, hematoma, and tamponade. Remember, they usually have small ventricles. A pseudoaneurysm is a concealed form of rupture which can be very discrete. Papillary muscle rupture results in acute mitral regurgitation, so you will have to look for these features. And you will find the papillary muscle which swings to and fro between the left atrium and the left ventricle. Ischemic VSDs can best be detected with color Doppler. They can be located in the basal part of the inferior septum or in the apical septum, depending on where the infarct is. And cardiogenic shock is usually a result of large infarcts. All these complications represent emergencies and need intervention, usually operation, with the exception, of course, of shock. Further complications are RV infarct, which is fairly frequent, where you will find a dilated right ventricle and a reduction of right ventricular function. Thrombus formation, which can occur both in the acute setting of myocardial infarction or in the chronic stages. Beware that you have to differentiate a thrombus, especially if it is small, from trabeculations. Aneurysms are a form of remodeling, which usually occurs with large infarcts, but which can also be seen in small infarcts. And finally, mitral regurgitation, which is associated with a poor prognosis and which is caused by geometry changes, in other words, displacement of the papillary muscles.